Hello everyone, this is Richard from Modern Healthspan. Today we're going to talk about TRiM and TRiMX. The lead author of both of these trials is Dr. Greg Fahy, the Chief Scientific Officer and co-founder of Intervene Immune, and we are honoured to be having an interview with him soon. TRiMX is a second phase human trial study which is aimed to confirm an earlier trial, TRiM, which was initially designed to test whether a cocktail of DHEA, metformin and growth hormone could rejuvenate the thymus. On further inspection, the team made the groundbreaking discovery that the drug cocktail had wound back the epigenetic age of the participants. Although TRiM had amazing results, it is a small scale with only 9 participants, and there was no control group. If TRiMX confirms the results of TRiM, this will be the first practical protocol to have been shown to reverse epigenetic age in humans with a cocktail of drugs. So what is the difference between TRiM and TRiMX? We're going to compare them after a brief summary of the published study on TRiM.
First, let's look at the TRiM study, what the protocol was and what they found. The write-up is in this paper, Reversal of Epigenetic Age and Immunosenescent Trends in Humans. Dr. Fahy is the lead author, and Steve Horvath did the epigenetic age calculations. The study used 4 separate epigenetic aging clocks and showed that they were able to reverse them. The protocol they chose was designed to regenerate the thymus. They observed protective immunological changes, better markers for many age-related diseases, and a mean epigenetic age of 1.5 years, less than baseline, after 1 year of treatment, so minus 2.5 years for the whole study period. This reversal accelerated after the 9-month mark from minus 1.6 years per year to minus 6.5 years per year. The GrimAge clock, which is specifically trained to predict morbidity and mortality, showed a 2-year decrease that persisted 6 months after the trial. This was a breakthrough study that was the first to show an increase in expected lifespan based on epigenetic predictor. So very briefly, what is the thymus and why do we need to regenerate it? I am not an expert in the immune system, so we will keep this very high level. First, what is it? It is the master gland for the immune system. It performs a number of functions, but one of these is maturing T cells so that they are able to function in the immune system. The thymus starts to degenerate when we are 12 or so, and around the age of 63 has become mostly fat and non-functional, a process called involution. This leads to a collapse of the T cell receptor repertoire and an increase in cancer, infectious diseases, autoimmune conditions, and generalized inflammation. So regenerating the thymus is important for our immune system and may have other knock-on effects. Hence they initiated the Thymus Regeneration, Immunorestoration and Insulin Mitigation, or TRiM trial from 2015 to 2017. The purpose of the trial was to see if recombinant human growth hormone could prevent or reverse immunosenescence in a population of 51 to 65-year-old men. RhGH was chosen based on previous evidence that it could impact the thymus in animals and human HIV patients. GH can, however, cause excessive insulin, so they combined it with DHEA and metformin to limit the insulin generation. DHEA has many actions that oppose deleterious effects of aging, and metformin is a powerful CR mimetic. Neither DHEA or metformin have been known to impact the thymus. So what results did they see? The first thing that they tested was for safety, and in particular there is always concern when using growth hormone that it will accelerate any cancer growth. So they looked for signs of increasing prostate cancer in the blood with prostate-specific antigen, or PSA. They did not see any increase, and in fact the indices improved from day 15. There is also a concern when activating the immune system that this would cause added inflammation. So they checked CRP and interleukin-6, markers of inflammation. CRP went down by a statistically significant amount by the 12-month mark, whereas IL-6 was essentially unchanged. They also checked other blood markers such as albumin, lipids, platelet count and others and saw no change. This graph shows the liver markers AST and ALT not changing. AP, alkaline phosphatase, did increase by an amount that was statistically significant, but the increase was small and still in range. Insulin and glucose levels also remain unchanged. So these numbers all look good. So the next question is, did it restore the thymus? The thymus is shown here by these white outlines in this slide, the one on the left being before and the one on the right being after. The one on the left has more white, which is the fat, but we can see the right has more darker areas where the regenerated thymus is replacing the fat deposits. And here it is graphically, where we can see that the fat-free fraction of the thymus decreases and compared to the baseline going into the trial increases by a maximum of over 200%. The thymus not only seemed to regenerate, but also started operating, creating new T cells, as we can see in this graph. Meanwhile, it also reduced the level of PD-1, an enzyme which stops the immune system from attacking cancer, so reducing cancer risk. Note that the trial ended at 12 months, so the uptake at the end happened after the trial was over. The other thing they found was that the lymphocyte to monocyte ratio increased, which is a good marker for the ability to fight many diseases, including cancers and cardiovascular disease. The decrease in monocyte is a positive sign on its own, as monocytes are one of the main carriers of CD38, the enzyme which consumes NAD, so this will help maintain NAD tissue levels. And finally, looking at the clocks. Initially, they used the Horvath 2013 clock, which showed a decrease over the trial, which was partially went back afterwards, but they wanted to confirm with the other clocks, and so they looked at PhenoAge, Hannum and GrimAge clocks, all of which showed a similar story. Perhaps the most important is GrimAge, as this predicts future morbidity and mortality, and we can see after the trial finished the gains seem to remain. So this is a quick summary of the original trial. Dr. Fay is now starting a new trial. Thymus Regeneration, Immunorestoration and Insulin Mitigation Extension Trial, or TRIM-X. The trial has started, but the recruitment is a rolling process and they are still recruiting. And it is sponsored and organised by Dr. Fay's company, Intervene Immune. The protocol is very similar to TRIM, and they will look at very similar markers, though I believe that they will add some based on their experience in the first trial. The combination of agents will be the same as TRIM, in that it will be a cocktail of human growth hormone, DHEA and metformin. In this case, there will also be a control group. The first study did not have one. This is a phase 2 trial with the aim of obtaining information needed for designing an effective, personalized and adaptive treatment, and to include a wider diversity of participants. Like TRIM, it is for 12 months. The drugs will be the same: human growth hormone, metformin and DHEA, although they have now identified the growth hormone as somatotropin, where it was not identified in the first trial. The controls will take metformin and DHEA, just not the growth hormone. The primary outcomes are epigenetic age, thymus regeneration, and safety and tolerability, with improved immune function as an additional outcome. The participants are from a wider range of ages, from 40 to 80, and will include women. Here is the summary of the differences for TRIM and TRIM-X trials. The TRIM trial had 9 males, while TRIM-X is targeting for 85, and will have a mix of men and women. The age range in the TRIM trial was 51 to 65, while for TRIM-X it is extended from 40 to 80, and the TRIM-X will have a control group, as we just discussed. The drug cocktail appears to be the same. As a note, in TRIM they also included 3000 IU of vitamin D and 50 mg of zinc. It is not clear if these will also be in the second study, but I see no reason why they would have been removed. What is somatotropin? It is a form of human growth hormone, and it's important for growth of bones and muscle. It is used to treat growth failure in children and adults who lack natural growth hormone.
I hope that you found the video informative. Please do hit the thumbs up button, subscribe to our channel, and hit the bell button for any new video release notifications. Thank you so much for your kind support. I wish you all well, and will speak to you again soon.